Well, very good. I'm excited to be here this morning. I'm going to be talking a little bit about qEEGs or quantitative electroencephalographies. We're going to go ahead and get my slideshow up and then we'll get rolling. I know one of the reasons I wanted to present this little case study today and dive deeper into qEEGs is that the topic of the conversation is advancing brain science through technology. When we're looking at qEEGs, they were really first started as a way to help with the diagnosis of psychiatric and psychological conditions, but we're using them more readily now in the fields of neurology and neuroscience. Very good. So I am the Director of Rehabilitation at a brain rehabilitation facility in Tampa, Florida called Genesis Brain Institute. At the end of the slideshow, I'll just have a little QR code if you want to see more about what we're doing. I'm a part of a multidisciplinary team, including neurosurgeons, psychiatric nurse practitioners, neuropsychologists, mental health counselors, pediatricians. So I'm just representing really a team when I'm speaking here today. All right, very good. We'll move and groove. So I wanted to go a little bit into a quick, brief background on TBIs and concussions. All concussions are TBIs, not all TBIs are concussions. Then we'll go into EEGs and really how they evolved into qEEGs and going from there into qEEGs and TBIs and concussions. And then I'll share a little bit about one case I had with the amelioration of his qEEG findings. So TBIs, major cause of long-term cognitive and functional deficits. This topic hits home for me as my father had a TBI from a car accident in his late teens, early 20s that he still suffers side effects from. But when we're looking at TBI care and how it's evolved from the 1980s to the 2020s, we really went from doing nothing except rest to having quite a diverse pool of technologies and rehabilitation services that we can offer now. When you're looking at TBIs, specifically in car accidents, 1 in 3 drivers will get a TBI from a car accident, and that was quoted in a Massachusetts study by Dizziness in 1999. I like utilizing qEEGs because sometimes you just don't see the same things on CTs and MRIs. When you're looking at concussions specifically or mild traumatic brain injuries, oftentimes there won't be signs on an MRI or CT. The other thing with CTs is that there's radiation. Other thing with MRIs is that you can't go in if you have different metal in your body. So depending on the type of pacemaker or spinal cord stimulator, you might just be limited in what you can do. And then some patients just would prefer not. I do work with the veteran community. Claustrophobia is a factor. Auditory trigger PTSD is a factor. So MRIs might not be something that they're willing to do. So qEEGs do offer a sensitive, non-invasive measure of neuronal network dysfunction that we can do in-house. The basics of EEG, you're basically putting electrodes over the scalp to read the cortical activity. You're looking at the waveform. So I just have up there just what an EEG would look at. Originally, they were just looked at by neurologists, just studying the squiggle lines and looking at the patterns involved. When you're looking at these squiggles, I am placing 19, really 20 electrodes with the ground wire on my patients' heads. They come in nice little caps. You can also glue them to the scalp as well. And then I'm looking at the different frequency bands. So the frequency bands are what we also refer to as brain waves. Delta is nice and slow from about 0.5 hertz to 4 hertz. 4 hertz is really that demarcation between delta and theta. Theta wave activity is going to be 4 to 8, 4 to 7 in some research. And then when you're getting into alpha activity, 8 to 12, sometimes 8 to 13. And then beyond that, you're hitting the betas. We like to separate betas into low beta and high beta, and then followed by gamma, which is anything over 30 hertz. I just want to make sure everything is good to go from a tech standpoint here. I don't put a lot of weight into my gamma recordings currently. You can get different interference with the electrical activity here in the States, especially at 60 hertz. But I do look very intensely at the slow and fast, so delta theta, and then into the betas for my TBI patients. And I'll show you why in a second. So looking at qEEGs, or quantitative electroencephalographies, You're looking at the quantification of the EEG data. So that's where we're using technology to our advantage. You do need to still analyze the waveforms or the line drawings or graphs created by the EEG, especially when artifacting. But when you're looking at the quantification, we can use mathematical algorithms to then create topographical maps based on the waveform activity. So what we like to do is called a fast Fourier transformation. The good news is you don't have to do it yourself or in your head. It's all a part of programs now to take all those squiggly lines and turn them into some beautiful pictures. It does produce objective metrics, and then we utilize metrics such as power, and I'll do relative and absolute power. We do coherence. I say it's kind of like when people speak coherently, you can understand them. So incoherent, we say hypocoherence, too much or too little. Phase, both phase lock, phase shift, and phase lag. And then asymmetries, right? Left versus right. And then the reliability for short epochs is greater than 0.9, and that was reported by Thatcher in 2010. Regarding qEEGs and the topic today, which is TBIs or concussions, there's a couple of key things to look for. And I do utilize a lot of the research by Robert Thatcher for this. He really spearheaded this. And then I use his database. So kind of going back when you're looking at power, coherence, phase, and asymmetries, I compare my patients to normative databases the same way that we do when we look at blood work or other metrics. So being able to have a reliable database to then compare your patient to other healthy members, their age, their gender, their handedness is important. So for all the images that you'll see today in my slides, I utilize the NeuroGuide database. I've utilized other ones as well, but that's the one I'm currently using for most of my patients. Very good. So what do we find? This is actually from a different patient, but oftentimes what you'll find is an increase in slow wave activity. This is an elevation of the power output of both delta and theta. Elevated theta you'll see in a lot of neurocognitive syndromes like the dementias or metabolic issues causing brain fog or memory challenges. The thought with this is that you're producing too much slow wave activity. So sometimes you'll feel foggy, right? You'll feel like you just can't think fast enough, or I can remember meeting you, but I can't quite remember your name, or I know what the word is, but I can't quite get it off the tip of my tongue. I hear that a lot of times with my patients. You'll also see abnormalities of alpha. Alpha tends to have a posterior dominance, but it can shift more frontally in different concussions or TBI states. You'll also see abnormalities in alpha in other conditions like major depressive disorders, things like that. You'll also see a decrease in beta power. So decrease in fast wave activity can make it feel like you just can't process fast enough, difficult with deductive reasonings or reward processings, things like that. And then going from there, you'll have alterations in coherence. So that ability to have crosstalk in the brain, both through the same hemisphere and across, or both inter and intra-hemispheric communications. It reflects the network disconnection and the reduced cortical synchronization, and they persist chronically and then create neurocognitive deficits, right? So when the brain doesn't work well, you're not going to be able to think well, or you might not feel well. There's also a nonprofit in the same town I'm in, which is Tampa, that's looking more at the neuropsychological effects of repeated head injuries, even when they don't all qualify for concussion, because you will see higher rates of suicide, higher rates of mental health issues, and higher rates of violence both towards themselves and others in people that have repetitive head traumas. And you'll see that on the news a lot, unfortunately, as well. So some strengths of the qEEG, it's sensitive. So a lot of times MRIs, you need these large lesions, big enough lesions that you can see them, but concussions are happening at a cellular level. When you're getting that stretching of the axons and changing the cellular activity, if it's a small enough injury, it just won't show up on an MRI. I do like CT scans and MRIs to make sure we're ruling out brain bleeds or larger deficits. So I do get MRIs on my patients, but I'd like to impress upon you that a lack of MRI findings does not mean a lack of concussion or TBI. It's highly reliable, it's very cost effective, easy to repeat. The limitations is that if you keep skipping around from the databases, you can no longer have solid comparisons. So I would implore you to find the database that works best with your patient population and then stick with it for comparative purposes. And then there's the accuracy is still considered moderate right now with the research. And then it's not meant to replace clinical judgment. It's not meant to be the only study that you're doing to diagnose concussion. It's really just there to complement, right? You still need to do your exams. You still need to look at other metrics as well. And of course, listen to your patients, right? Nothing beats a good, solid history. So sharing with you a little bit about a case study. I had a 46-year-old male presented 2 months after a car accident. He was the driver. I actually saw him and his wife. They were at a red light. Semi-truck's brakes failed, hit his car, pushed his car, sandwiched into the car in front of him, and then actually pushed the entire unit into the car in front of them. So a 4-car pileup. He was vehicle number 2. He had a loss of consciousness. The good news with loss of consciousness is that he didn't have a lot of PTSD symptoms because he didn't really remember the accident, but he did have symptoms including headaches, eye strain, eye pain, visual disturbances, balance issues, and then these cognitive challenges, forgetfulness, anxiety, and then a significant number of musculoskeletal complaints as well. I think he had wrist pain, neck pain, back pain. All right. He was assessed. I utilized my 19-channel EEG and then quantified it. And then I also use a Rivermead post-concussion questionnaire. I have them with me if you want to see it. It's a standardized questionnaire. I didn't invent it or anything like that, but I utilize it for all my patients. And then I do other assessments as well, but we're hitting on these today. Other assessments I like to do are balance assessments. I do a modified clinical test of sensory integration and balance with a cervical challenge, which is looking at balance in 14 different positions. We utilize video oculography, so I can look at the eyes in the dark, in the light, pursuit, saccades, optic kinetics, VORs, convergence, and divergence. And then we do pupillometry as well. That's kind of a newer thing that we started this year to complement the other components that we have. Overall, he scored 22 on the Rivermead, which is kind of that in-between range. Anything between 16 and 35 may be indicative of post-concussional syndrome. And he had 2 or more. So like when you do a Rivermead, it's graded 0, 1, 2, 3, or 4. So he had 6 out of the 16 questions he was scoring over a 2 on, meaning that they were still impacting him on a daily basis. So let's look at his brain, see what it looks like on the qEEG. He did have a focal elevation of delta at 1 hertz, a focal elevation of theta at 4 hertz. We also looked at his Laplacian absolute values, which showed a depression of high beta from 21 to 25 hertz. And then you can see actually a depression of that beta at 17 hertz and 21 hertz on a Loretta, which is a low resolution way to look at the qEEG as well. And then here are his coherence maps. You'll actually see a lot of hypercoherence in TBI cases because the brain's trying, it's trying to recover. You'll get a lot of crosstalk. So you'll actually see more hypercoherence than hypocoherence, especially in the acute phase. Several years out, you might be seeing more hypocoherence, but in that acute phase, that first 1 to 2 years, you're really looking more at hypercoherence as the brain tries to reorganize and restabilize its own networks. And then we did rehab. This is the best part of my job, is getting my patients to feel better. So we utilize a multi-modal approach at Genesis Brain Institute. This gentleman engaged in 10 treatments over 3 months. I did ask for 10 treatments over 3 weeks, but patient compliance is always a challenge. But we utilized hyperbaric oxygen. I use a soft chamber. The research is still like ups and downs regarding hard versus soft chambers, but I do a 1.35 atmosphere with concentrated oxygen, roughly around 90% at 10 liters per minute. He did hour-long sessions, not including pressurization time. So we did that 10 times. And then I like pulling him out of the chamber and then immediately going into all the other rehab, right? If you're going to take pre-workout and protein, you better go work out afterwards. So our pre-workout and protein in the neuro rehab realm is the hyperbaric oxygen and the photobiomodulation. I utilize transcranial photobiomodulation at 808 to 810 nanometers, which is a form of near-infrared light. And I utilize the qEEG to help me figure out which brain regions I'm going to light up or increase that blood flow to, utilizing our transcranial photobiomodulation devices. So that's the third image there. It's just a little laser he's moving it towards the head. It has to touch the scalp to decrease scatter effect. We also utilized electrical stimulation of the vagus nerve and the median nerves. The median nerve, for a couple different reasons. He did have some wrist dysfunction, but there's also some combining of the median nerve with the ascending activating system that helps with consciousness and did alleviate brain fog. And they're utilizing this in some research for people that are in comas as well. So I do a much lower stimulation threshold for the median nerve. And then we went into vestibular rehabilitation. He had balance issues and dizziness. So good old fashioned vestibular rehab, nice and low tech with some ×1 viewing exercises. And then because he had some anxieties, I did utilize virtual reality biofeedback for heart rate variability and breath rate and rhythm. And then some good old-fashioned neuromuscular reeducation, utilizing some oculomotor exercises, which is just a way to give eye movement exercises to patients with visual dysfunction. You have those 6 little muscles around each eyeball. The nerves for those start in the brainstem. It's a nice long pathway. Between the pathway of the nerves and the sensitivity of the actual eye muscles, you can just injure, or strain or sprain these different muscles as well, the same way you can your neck muscles, right? So we do the video oculography to screen for these eye movement dysfunctions and then prescribe specific ocular motor exercises for those patients. And the good news is it got better. So we had an amelioration or resolution of the qEEG findings. His symptoms got better by about 40%. He was still in pain. And I tell my patients too, when your main symptom is memory issues and visual issues, and then after I treat you, your main issues are back pain, that's good. I move you along to another team member of mine to get the pain taken care of. And then he had a 40% decrease in his Rivermead post-concussion questionnaire symptom total. And then we went from six symptoms that were rated above a 2 on the Rivermead down to just 2. And then his coherence maps greatly improved. And then just as a summary, we have the elevation of slow wave activity improved, the coherence abnormalities improved, and the depression of the fast wave findings also improved. So very good. So kind of clinical implications, qEEGs can be utilized for more than just the realm of psychology and psychiatry. You're looking at brain function. The electrical activity in the brain is dependent on healthy brain tissue. So damaged brain tissue will create abnormal electrical signalings. So being able to utilize a type of brain imaging that looks at the electrical activity can be helpful. It's useful for guiding neurofeedback and neuromodulation techniques. When it comes to the brain, customization and individualization of care plans is everything. Every brain is different. Your brain is as unique to you as your fingerprint. So if you get a brain injury, that's going to be as unique to you as well. And you deserve a treatment or care plan that's also unique. So being able to utilize the scans of the brain to then create a more customized and more specific treatment plan allows us to create shorter treatment plans with bigger results. And then my only other comment here is that nothing beats having trained clinicians and utilizing a dynamic approach. Every patient will need something different. So being able to understand that and figure out what they need is an important part of the process.